Good afternoon, everyone. Uh, the topic is about the comparison of conventional trabeculectomy versus trabeculectomy with deep sclerectomy. No financial interest. Trabeculectomy has become the most commonly performed surgery for the reduction of intraocular pressure, and various technical modifications have been developed in this procedure. One among this is a trabeculectomy with deep sclerectomy, which claims to eliminate or minimize the complications of classical trabeculectomy. Aim of our study was to compare the efficacy of conventional trabeculectomy and trabeculectomy with deep sclerectomy. So this was a retrospective study conducted between January 2018 to June 2022 on 60 eyes of 60 patients with medically uncontrolled glaucoma. Informed consent was taken. The inclusion criteria includes patients with glaucoma with uncontrolled IOP with maximum tolerated medical therapy, and exclusion criteria include patients who underwent combined glaucoma and cataract surgery in a single sitting. So the complete ophthalmic evaluation was done, which includes a best corrected visual acuity, slit lamp examination, applanation tonometry, gonioscopy, fundus examination, and HFA. And the group was divided into two groups of 30 patients each. While the group 2 underwent conventional trabeculectomy, group 1 underwent trabeculectomy with deep sclerectomy, in which after placing the corneal traction suture, the conjunctival peritomy done, tenons exposed, careful hemostasis done, 0.2% MMC sock sponge is applied subconjunctivally and removed after 2 minutes, followed by a thorough wash. A superficial scleral flap 1/3 of thickness, 4 into 4 mm, hinged at the limbus was dissected 1 mm into the clear cornea. Then a 3 into 2 mm flap of deep sclera was dissected under the superficial scleral flap, extending up to the limbus and cut with vanus. Anterior chamber is then entered under the superficial scleral flap, and trabeculectomy is done as in the conventional trab method. Followed by a peripheral iridotomy, superficial scleral flap repositioning done. Postoperatively, all the patients were given with prednisolone acetate 1% eye drops in tapering doses for 8 weeks, moxifloxacin 0.5% eye drops 4 times a day for 1 week, and atropine 1% eye drops in tapering doses for 4 weeks. And the follow-up data was collected at day 1, 1 week, 1 month, 3 months, 6 and 12 months postoperatively. Complete success was defined as postoperative IOP of 6 to 16, between 6 to 16 mm of mercury with no anti-glaucoma medications, and qualified success was defined as postoperative intraocular pressure less than or equal to 16 with anti-glaucoma medications. These are the characteristics of the patients in the deep sclerectomy group and the TRAB group. The mean age was 58.03 in group 1 and 57.2 in the group 2. Male is to female ratio was 18:12 in group 1 and 20:10 in group 2. Mean pre-op IOP was 29.77 in group 1 and 32.23 in group 2. Mean duration of glaucoma was 3.83 years in group 1 and 3.63 years in group 2. So this shows the change of intraocular pressure at different time points in both the groups. So it can be seen that there was a significant IOP reduction after surgery in both the groups throughout the entire follow-up period. Regarding the postoperative complications, 7 eyes out of total 30 eyes in group 1 had postoperative complications. That is 23.3% in group 1 had postoperative complications. Among that, 6 eyes developed high IOP, 1 eye developed wound leak, and in group 2, 5 eyes among the total 30 eyes develop postoperative complication, which includes 3 eyes having high IOP, 1 eye having wound leak, and 1 eye developed NVI. Regarding the postoperative surgical interventions, 7 eyes in the group 1 needed postoperative surgical interventions to control intraocular pressure, which includes 5 underwent bleb needling, 1 eye underwent resuturing, and 1 underwent diode CPC, and 4 eyes among the group 2 needed post-op surgical interventions to control IOP, which includes 3 underwent bleb needling and 1 underwent resuturing. Regarding the success and failure rates, 63.3% had complete success rate, 20% had qualified success rate, and 16.7 had failure rates in both the groups. Regarding the AGM usage post-surgery, it was seen that 10 patients in the group 1 needed more AGM compared to the group 2. According to our study, the intraocular pressure lowering effect is comparable between the two groups. No significant differences in the absolute or qualified success rates noted. Complication rate and the need for multiple AGM post-surgery was found to be more in the deep sclerectomy group. Complications noted were more having transitory hypertony, then noted was shallow or flat anterior chamber, and then comes the blood-related complications. No serious complications like severe hyphema, malignant glaucoma, or any persistent choroidal detachment noted. Our study shows that the rate of complication is more in the deep sclerectomy group compared to the TRAP group, which was statistically significant. So it can be concluded that both trabeculectomy with and without deep sclerectomy seems to be a valid and safe alternative to lower the intraocular pressure. These are my references. Thank you.
Good presentation. But I have a little bit of a worry about the technique.
Okay.
You did show us a video.
Yeah, that was only the deep sclerectomy step, not the entire trap because of time constraints.
Agree. But what's the point in putting in a hole if you are doing a deep sclerectomy?
So I didn't get you.
Say, why are you doing a trabeculectomy on top of a deep sclerectomy is my question.
This was actually an additional step, deep sclerectomy. Like after
the question is, which one is the addition? Are you adding the deep sclerectomy or are you adding the trabeculectomy?
Deep sclerectomy is added to the conventional TRAB method. Like the trabeculectomy is already there. Then addition to that,
trabeculectomy was not there.
No, I didn't show actually.
Yeah, and you were doing a deep sclerectomy.
Yes, sir.
Fine, which again is not classical deep sclerectomy, but that's fine. Yeah, Mike.
This was actually penetrating type, not the.
Yeah, so you see, once you penetrate, you lose the advantage of the deep sclerectomy, and you're just adding on something for as your study shows, for nothing and getting a few more complications.
Yes, sir.
Okay.
So we are actually finding
either believe in one thing or believe in the other thing, and just go for it.
We were actually trying whether we get any like added advantage with the deep sclerectomy.
You got the complications.
Yes. It was found to be. Yes, ma'am. Oh, sorry. Yes. Or trab. Me is lost. Okay.
Okay. Yes, you presented well, everything's fine, but there's that little flaw at the very beginning. It's not your fault.
Yes.
Obviously, whoever's doing the thing.
Okay, sir.
Yeah. We all learn.
Yes, sir.
And I do a lot of these, right?
Okay. Okay. Thank you.